we can start the program now. So.
Yes, Dilip, will you get started? Yeah.
Hello, am I audible?
Yes, you are. You are.
Okay,
yes.
fine.
Yeah. Yeah.
So friends, we are starting the meeting. The meeting is being recorded. Today, March 13, 2023, and this is the second Monday of March Myeloma Action Month. With the lot of efforts by Image South India chapter, this patient group meeting is organized, and we are lucky to have Dr. Hari Menon from St. John's Hospital, Bangalore, and we are going to have Dr. Neeraj Siddharatan, Dr. Sada Shivru, Dr. Pankaj Malhotra, Dr. Stalin Bala Chaudhary. Also, they are going to be with us. Today, Dr. Y. Uday is busy with some emergency. So today's meeting is going to be moderated by me. I am Dilip Kumar Mewada, a Myeloma Friends Charitable Trust founder trustee. Thank you very much. And today also we have गायत्री जी क्या नाम था उनका मैं भूल गया our
Krishna Veni.
We have Mrs. Krishna Veni from Yodhas. She is going to share her experience in 10 minutes. So over to you, Mrs. Krishna Veni, for sharing your experience about dealing with myeloma.
Okay, thank you, Gayatri ji, for. I hope I'm audible, please.
Yeah.
Thank you, Gayatri ji, for inviting me to share my story during the multiple myeloma action month. So, my name is Krishna Veni, and I'm from Hyderabad. I studied BTech in Electronics and Communication Engineering, and then joined a government organization. I worked in their IT department for almost 30 years. And then I took premature voluntary retirement when I was 51 years. That was 2 years back, and I am now 53 years old. So I just want to share a little bit about my pre-diagnosed state, the status of my health when I was in my teens. Okay, so I was always an anemic child, and I was taking a lot of iron supplements on the advice of a physician. And I always frequently suffered with sore throat and sore throat infection problems, and took antibiotics. And every time I had a sore throat, it used to be followed by asthma attack, and I had to use an inhaler. And another problem I faced since I started having my periods was I used to have severe cramps, and for that I was taking a painkiller also on the advice of a gynecologist. So I was supporting myself with all these medications, and I had got married when I was 25, and I had a son also. Everything was okay. I was able to manage, but what happened in July 2011 was I fell down the stairs and had one L5 compression fracture. So this we didn't know what was coming in the next few months. So I was 42 years, and that was October 2011 when I became very sick, and I started having fever with the chills. So I went to a local physician who advised me to go for a blood transfusion because my HB levels were at 6. So we wanted to take a second opinion, and we visited a corporate hospital in Hyderabad. And after several tests, including a bone marrow test, I was diagnosed with multiple myeloma. I then Googled on my phone for these words, multiple myeloma. I was hearing it for the first time. and I saw that the results displayed this word called cancer. I was totally shocked and devastated. I didn't do any more further research on what it was and anything else on this particular thing. But then while meeting my doctor or in the hospital, I was there for 3 days, and none of them, including my doctor, nurses, or family members, nobody used the word called cancer. And everybody made me feel so normal, as though it was a very simple problem and that I will be getting the best treatment. And I was in denial, and I told myself, I don't know what, I'm going to reverse it at any cost. So immediately in October 2000 itself, that treatment had started in Apollo Hospital, Hyderabad. And I was given 3 cycles of chemo followed by stem cell transplant. It started in the fag end of December 2011, and I was discharged in the mid of January 2012. So my doctor had, when my doctor advised for autologous stem cell transplant, we didn't have any doubts on him because he was very confident, very friendly. He made us feel so comfortable, and I just handed over myself to him basically. Though my family got a second opinion and they got the same response that I would have to go for the ASCT. And we didn't ask too many questions about the treatment. And we just went with the flow, and then the whole process was very smooth. And yes, I did go through all these side effects, and it took 6 months for me to get back to my normal, presentable state so that I could go back to work because I had lost a lot of weight and my skin was totally tanned, very dark. And yeah, coming to the support that I got from my family, my parents, they took actually care of me like a baby. And at this point, I would like to mention that the role of caregivers is very, very important during the recovery phase and all throughout the life of the patient. They have to make them feel very, very normal. This is a very important part of recovery. And even at work also, all my colleagues, they encouraged me to take up new projects, and they never ever made me feel like a patient or that I was sick and I had been, and I'm so and so, in quotes. So things were normal in 2012, 13, and 14. But what happened at the end of 2014, I noticed some small pus formation on my big toe. And after the bone marrow test, the doctor said there is a relapse and I have to go for a second round of transplant in April 2015. So he gave me 3 months time. And so immediately I asked my doctor, is there anything that I can do to help myself? At that time, he suggested, why don't you try Kinospora cordifolia? And he also said, why don't you just relax and do some gardening? So I came home, I took some fenugreek seeds, meaty seeds, and put in the soil. And I also opened my laptop and started searching for Kinospora cordifolia. So this led me to one blog of one Miss Margaret. She lives in Tuscany in Italy, and she was managing her smoldering myeloma condition for 8 years by taking all herbal supplements like curcumin, ashwagandha, satavari, etc. So I had some confidence in her, her blog. She had put a lot of posts on her condition, how she is managing. So I went online and checked for these particular supplements, and I found them on Himalaya, and I started taking them. So January 2015, February 2015, and March 2015. Every month, end of the month, I used to go for the blood test, and every month we saw that there were improvement in my parameters. And when it was April, my doctor did not mention about ASCT at all. And then I just continued. I was taking lenalidomide at that time. And I told him, I'm taking turmeric. I'm taking turmeric and tinaspora because he himself had advised me to take tinaspora. So, and he did not say anything, he did not comment anything. And I just went ahead. But very soon I came across Yodas and Gayatri ma'am, and she helped me to get hold of curcumin from an Ayurvedic doctor in Mumbai. So since around April, May of 2015, I started taking actual curcumin and other herbal supplements from Ayurveda doctor. And in 2016, when I went for my bone marrow test again, my doctor said you can stop lenalidomide also because I started getting some other infections like stomach upset and some skin rashes and all that. He said, you could stop lenalidomide, all your other parameters are fine. And he also said it is 5 years since your transplant. You are technically cured. So you don't even have to visit me every 6 months for a bone marrow test. You just get a test done at home and see for yourself the result. If there's any change, you can come back to me. So this was how things have changed. And there are some other self-help methods that I have been following along with this complementary treatment of herbal supplements. I avoid taking and minimize these 5 white foods, which are sugar, salt, maida, milk, and polished rice. And I also fast once or twice a month. And preferably, it's good if you can fast once every week. And I get my vegetables and fruits from organic farms. I make sure I get vitamin D, that is from the sun, every day. And I reduce potassium-rich foods and high-protein foods so that my uric acid levels and creatinine levels are maintained. And I do pranayama twice a day, morning and evening. I do meditation. I have also consciously changed the way I think, because I definitely feel that the thoughts in the mind have an effect on the body. And gardening has been therapeutic, and I enjoy my time spent in the little garden that I have. Another time that I have, I spend on my spiritual quests and do some minor practices also. And to make my life more comfortable and so that I could manage my work and home comfortably, I employed a driver, a cook, and a maid also to, help me manage. And after my treatment, I continued to work for 9 years. And then I said, no, that's enough of my 30 years of service is enough. Let me just retire, relax, spend my time with my family, myself, and to pursue my passion and to help other myeloma patients in whatever little way I can. And I retired after 30 years of service. And I make sure that I have immediate goals, short-term goals, and long-term goals, which make me look forward to the next day, the next week, next month, next year, and so on, to keep me going. And I also plan my diet well in advance so that I manage to get all the nutrition required. And I forgive myself and others. I accept people as they are. I feel grateful for my blessings. So these are the changes that I have made in my life. I try to follow them to the maximum possible. So this is my life story. So 3 years of allopathy plus allopathy. I had taken 1 year of allopathy and herbal supplements, and 7 years of herbal supplements I have been taking. And this is how I am today, as on today. Thank you for listening to me patiently.
Congratulations.
That's it from my side, ma'am.
My request,
Can you please
Varun
share
ji,
your herbal
Varun ji.
Yes.
My request to all of you to because I am the moderator, I'll give everybody a chance to ask the questions. You can ask the questions on the chat also, and I will see that everybody gets satisfied with their with the answers. So we'll give that. So first of all, people who have not put their mic on mute, please mute that. Please mute that, because a lot of disturbances are there. Please. Thank you. Richa, you have to mute your mic, please. So, Krishna Veni ji, your story is an excellent and wonderful story, and there is a lot of learning out of this particular thing. हम लोगों ने बहुत कुछ मतलब आपकी स्टोरी से हम लोग इंस्पायर हो रहे हैं, हम सारे लोग इंस्पायर हो रहे हैं. And one more thing is, apart from the allopathic medicine and that is working and doctors are doing, what you tried is a naturopathy, meditation, yoga, gardening, and all these things. See, these are not interfering with the allopathic medicines basically, and the substitutes that you have taken is also, you know, it is helping in our healing and curing basically. So your story is fantastic, and I would like to congratulate on this particular thing. And thank you very much for being our guest and sharing your experience with all these things. And please keep on sharing your stories, your experience with all these patients and caregivers. It will definitely boost our morale, and it will also give a lot of inspiration and motivation to live longer and longer. And one day
Sure.
we are definitely curing it. That with that aim, we are actually working. All of us are working at Myeloma Friends, Image Society, or Yoddhas, or any other NGOs. So thank you very much for being here, and thank you very much for sharing.
I just
Okay.
wanted to mention one more thing,
Yeah,
one final thing. Actually, I wanted to share my experiences by a book, writing in the form of a book, which actually I have completed, and very soon it will get published. So once it is completed, I will share the link on Amazon to all of you so that you can see in detail all the things that I have experienced.
That's really wonderful. We would like to see that. And last Monday, Dr. Uday had also requested all the cancer, the myeloma patients and caregivers to write a story and send it to Image Society. At least 100, 101 stories we would like to have. And a small story and experience needs to be shared. And that book will be compiled by Image Society to inspire and motivate myeloma patients. So thank you very much. Thank you very much. Thank you.
Okay.
So now next is I invite Dr. Neeraj Siddharthan. He is going to talk about the relevance of MRD analysis in myeloma. So over to you, Dr. Neeraj Siddharthan.
Thank you, sir. And thank you to Image and Yoddhas for giving me this opportunity to be here. And then I'll be very happy to be with you today. Can I share my slides?
Yes, please. Yes, please.
Thank you.
Is it visible, everybody?
Yeah,
it is visible.
Okay. All right. So in the next 10 minutes or so, I mean, I was so inspired to hear what Krishnamani ma'am had to tell about her story. And, we are in an era now where doctors and patients and caregivers and everybody associated with this disease, myeloma, is speaking about the word cure and trying to go for cure. So that it is in this context that Uday probably wanted me to speak about MRD, or minimal residual disease, or what you call it as a measurable residual disease in myeloma and its relevance. So I'm going to keep it very short, and the idea is to just touch upon this concept so that all of us are aware about this. So in general, I mean, I'm just as an introduction, starting with all of probably that, when do you suspect myeloma? Generally a disease of older age, but in India, it is 1 decade younger, probably 69, 70 years is the average age in the West, whereas 59, 60 years is in India, I think, with many data seems to show. And in that age group, or sometimes in younger age, we have seen myeloma as young as 19 years, but you may present with anemia, where you have weakness, dizziness. Some may have a trivial fall and then have injury, and then unexpectedly have fractures or some bone pain, which is kind of diffuse and not really fitting into a joint pain. And sometimes with somebody may present with bleeding symptoms, obviously due to some coagulation abnormalities or platelet decrease. Somebody may present with very high calcium levels, and in effect you may have confusion, weakness, drowsiness, etc. And then sometimes the proteins can affect the kidneys, and then it can damage. And so you may have frothy urine or decrease in urine or your creatinine going up. And sometimes you have a compression symptoms, you have your nerve symptoms, that numbness and muscle weakness, etc. happening. So these are some of the common symptoms in myeloma. And then at present, we know that we have enough diagnostic instruments and technology available in our country. Earlier, the diagnosis was a little difficult, probably because of the unavailability of many of these things. But you can see now, earlier, it was only X-rays that are available to see fractures or bone lesions. But now we have more advanced technologies like, let's say, MRI, or go more deep and find out at more earlier stage than what an X-ray would detect. Similarly, you have many new tests, let's say, like free light chains and immunofixation, which was not earlier available in India. So these tests are now available so that the patients are diagnosed earlier than before. And when you diagnose earlier, and then of course the chances of having a better outcome is much more. So, we should all know that this myeloma is like a continuous disease, starting from what you call as MGUS, or what you call monoclonal. You may have an abnormal protein without it necessarily being cancerous. From that, then somebody may evolve. Maybe 1% or 2% may evolve into a more advanced stage. So if you have a higher intensity of protein and a higher percentage of the abnormal cells in the bone marrow, still you may not call it a multiple myeloma. You may call it a smoldering myeloma, because you have a smoldering myeloma earlier where there is no anemia. What is this CRAB? CRAB is calcium, renal failure or kidney failure, anemia, and bone lesion. So if you don't have any of these, earlier we wouldn't treat. But now, with more advancement in in the treatment, we identify more patients earlier, so that an early treatment. It's just the concept is that like in any other solid cancer, like a breast cancer, you find early and you treat early and you cure. So earlier we used to think myeloma wouldn't get cured, but with this understanding of the disease, that myeloma can be picked up at the earlier stage than a multiple myeloma, which is more advanced stage. And now people have started treating at an earlier stage. And obviously with some differences are there then, but largely selected patients at an earlier stage, when you treat without them actually, before even they develop the renal failure or bone lesions, you tend to probably get a better results. Another very important advancement that has happened, as we said, the more India is actually seeing a laboratory revolution. You can actually diagnose everything now in India. So we know myeloma it's always called multiple myeloma, obviously because of the CRAB and all different symptoms that the patients present with. But at the if you look at the genetic level, I'm not meaning the hereditary, but at the genes which causes the cancer genes. In myeloma, now there are different cancer genes. So every one patient's myeloma is not different, is not similar to another patient. So there are at least probably now experts say 6 different types of myeloma based on the cancer gene. So it's called then multiple myeloma because it's not the same. And earlier we wouldn't know that, okay, why some people do bad and why some people do very good. So there are inherent risk features. Now we are trying to identify it using many biomarkers, that okay, if you express these markers at diagnosis, then maybe you are at lesser risk, or if you express a little bit different biomarkers, then you are at a higher risk. So that at the beginning, at the diagnosis itself, the physician and the patient and the caregiver, everybody knows, okay, we are here or there. So it makes an important, it's very important in the clinical decision making. Why? Because there's a lot of drugs now available. If you can see You cannot count. Earlier, when I used to be an M student, there was only one drug that I knew, that was melphalan. Then I knew about a few more other chemotherapies, vincristine, adriamycin, dexamethasone. Vincristine and adriamycin is not in this. Is it in this list? It's not there. So it has changed, completely changed. So a lot of types have come, which is acting in different ways, and you have immunotherapy, you have CAR T cells, whatnot. So you know that you can treat myeloma at diagnosis, and even at relapse, you still can treat myeloma, and many patients can still get long-term survival even after a relapse, even if you have been diagnosed earlier and then relapse. So in that context, so in the larger, so you know that earlier you can diagnose the disease, and also you have multiple drugs to treat the disease. Now you should also have in this context that MRD is important, or minimal measurement of the residual disease is important, because the lower you go, the minimum number of cells that you have, then the better results that you're going to have. You're right. So you see standard, let us see, try and find out how many cells you have. You will have 10 to the power of 12 cells at the time of diagnosis of multiple myeloma. Now, when you have a complete response, you will still have 10 to the power of 10 cells, right? So it's like even at the time of when we think that the disease is in complete remission, you have so many cells remaining. So that is when people have tried and looked at to find out by some test, identify these cells which are up to 10 to the power of 9. So you can identify it either using a technology called flow cytometric, which is called immunophenotypic CR, and then also by next generation sequencing or molecular testing. So these are the two technologies by which you can currently find out minimal residual disease. So here you have the flow cytometric plot. Actually, you can see those plasma cells in. This is the normal cells in blue, and this is the abnormal, cell in the red. And then this is the other technology, which is molecular testing, basically by isolation of DNA. And this test sometimes, and in future, I think it looks very exciting that these kind of tests of finding out the minimal disease can sometimes in future be found from the, I think, peripheral blood itself. You may have circulating DNA and then find out, even without doing a bone marrow in future, we may be able to find out that. So what is the importance is that, as I said, if you have a complete remission or something, so you would, if you are here in this graph, then this is relapsing here at this time point. But if you're lower down in this graph, the more negative you have, then you are relapsing later. And sometimes, you may have a very deep remission, that the depth of remission keeps increasing. The risk of relapse comes down, and at some time point, we may reach a point where, some of the patients may actually get cured. So this is the concept that, eradication of tumor cells is necessary for cure. And, the exception, of course, is that somebody may have an MGUS like profile. So here you can see that, we have a complete minimal residual disease negative patient, and this patient at least now have a chance that he may not relapse at all. So that is the importance of MRD negativity. So if you compare it with, let's say, an iceberg, and this is the tip of the iceberg that you see when, that's the number of cells that you see when you have a newly diagnosed myeloma. And then you go down to have a PR or complete remission, stringent remission. And then you go down to molecular CR. And then even below that, maybe an undetectable MRD, and then ultimately a cure. So we have actually managed to come deep down till when we started here, and we have managed to come deep down till here. And I think it's only a question of time when we actually are able to say that we cure myeloma. So, and also, this is from the bone marrow, and there is also the imaging, like what you can see here is the PET CT, and you can see very small lesions can be picked up, even if everything else is normal on images like X-ray or the routine CT also. PET CT or MRI, those images can sometimes pick up very, very, very subtle lesions also. So there are the different definitions are there. I'm not going to go into the scientific details in this presentation, but we know that, either by one of those methods of flow cytometry or LDS, you can have minimal residual disease defined as negative. And if at present, if your doctor asks you to do this, sometimes they may ask you to do it 2 times, maybe one year apart, and see that it is sustained negativity. Sustained negativity, those people who have sustained negativity is found to have a better result. So, and then if you have a negativity in the bone marrow and also a negativity in the image like a PET scan or then it is all the more better. And now, basically, now what has happened is that people have a lot of studies have looked at the MRD and the survival. And actually, you can see in this picture the red lines and the blue lines. Now, this is actually a combination of people who have gone for transplant and not gone for transplant. Generally, we would expect all those who have gone for transplant do better, but irrespective of that, what the red lines actually show is that even those who did the transplant better, but the next best was actually those who had MRD negativity even without transplant. So MRD negativity with or without transplants did better than those who had MRD positivity. Similarly, risk stratification, even though you are high risk before, if you become MRD negative, then your risk is becoming less and your response is much better. And this is like a surrogate marker that if you have an MRD negativity, the more chances are that you are actually going to have a better survival and better survival without relapse. So at present, in clinical practice, MRD is probably evolving. Probably like maybe doctors are only starting to do in clinical practice. The guidelines are still blurred, but at present we know that those who do MRD negative do much better than those who are MRD positive. So this slide actually shows that international there is a consensus. All the doctors and scientists have come together and defined certain things that when MRD should be performed, when it should be, what is the method that it should be done, and how it should be reported, what is the sensitivity. Everything is now getting defined. And so many a time this is a very, very useful information because we have so many drugs in hand. And so of course people are trying to look at, okay, let's say if the MRD is positive, what if we add another drug or something like that. So I think the future looks very exciting. And along with the fact that we are identifying myeloma early, and we have, along with the fact also that we have a very long list of very effective drugs that is there to treat myeloma. The third and perhaps even more important thing now towards the cure of myeloma would be this revolutionary tool of minimal residual disease. And if which is negative, then that is like one big step towards cure. So I would end with this, picture of Neil Armstrong landing on the moon and the famous dialogue that he said that it's a small step for man, a giant leap for mankind. So the MRD, I would say, it's a small step for assessment of the disease, but a giant leap towards cure of myeloma. With that, I would thank once again the Image and Yodas for giving me this opportunity, and thank you all very much.
Thank you, Dr. Neeraj. Thank you very much for a wonderful presentation and a detailed explanation. And this has actually, made us really, lot of educations were there. And we are shifting to the question answer session. And these questions will be answered by Dr. Neeraj, Dr. Pankaj Malhotra. Pankaj sir, are you there? Welcome to this webinar.
Yes,
And and Dr. Sada Shivdu, I think he has not joined, but in his absence, Dr. Stalin Bala Chaudhary is there. So I welcome Dr. Stalin Bala Chaudhary also to answer a few questions. Sir, my question to you is to investigate MRD negativity. At present, doctors are suggesting for bone marrow biopsy. Right? Is there any other way of testing without undergoing a painful bone marrow biopsy?
Okay. Can I take the question, sir?
Yeah, you can. Any these questions to any three of you.
Okay.
Yeah.
Thank you for the question, sir. So yes, the current practice is that we do the MRD with the bone marrow aspiration, not a biopsy. You can do it with the aspirate, and usually we send the first pool for MRD analysis. And what is available in our country and widely used is the initial method, which I said, that is a flow cytometric method. And there is also this NGS-based methods, and people are also trying to look at, as I mentioned in one of the slides, that whether this can be done from the peripheral blood. Now, there are different methods by which there are studies which have looked at getting plasma cells from circulating plasma cells using flow cytometry from the peripheral blood. And those information is coming up. So at present, the standard still continues to be the bone marrow, but in future, I think this is one important question people are trying to answer, and a lot of research work is going on in this. The other thing is, of course, not a substitute for bone marrow, but you're looking at something elsewhere in the body, the bone lesions and all that. So imaging like a PET CT is also very important to detect a minimal residual disease. That's an image wise.
Okay, great. Pankaj sir, आप कुछ बताना चाहेंगे?
So, as Dr. Neeraj said, currently we have only a bone marrow examination, but sometimes in the clinical side, what we do is, and Dr. Neeraj did mention about that, since bone marrow is a painful procedure, so many times what we do is we do a PET CT scan. If PET CT scan is negative, then we suggest, okay, now you go for a bone marrow examination to see whether the MRD is negative in the bone marrow also. But if, let's say, PET CT is positive, that means anyway you have to continue the medications, and sometimes we can avoid the bone marrow, because even if the bone marrow is negative or positive, if PET is positive, you have to continue the treatment. So, and the second thing is, even though you mentioned it is a painful, but the bone marrow MRD is done generally on the aspirate sample, which is not that painful as the biopsy. So, but when we are suggesting a bone marrow examination, we do want both aspiration as well as biopsy to be done, because we really want to have good information about what is happening in the bone marrow environment also. So it gives a lot of information about what medicines to continue, how much dose to continue. So even though it's a painful test, but it gives us a lot of information. So I would suggest that there are now methods which can decrease this painfulness of the bone marrow examination. But since it is a useful test, so I would urge all patients that at least they should go for this. Thank you.
Thank you. One more question to Dr. Sada Shivdu, that or Dr. Stalin Chaudhary, that how soon we have to do this MRD negativity, and I mean when it is to be performed. In the meantime, any two of you can, Pankaj sir or Neeraj, any one of you can definitely.
So MRD test is done generally when we are thinking of that the induction treatment is complete. Last time I said, there are three phases of treatment of multiple myeloma. One is the induction treatment, the other is consolidation, and third is the maintenance treatment. So once the induction treatment is over and we want to go to consolidation, so we would like to assess at that particular time. The second assessment is done post consolidation. Let's say somebody has undergone a bone marrow transplant. So we would like to see at 3 months or day 100 that what is the status of MRD at that particular time. And then on maintenance, somebody who is on maintenance treatment, then ideally it is yearly requirement. But as said before, that it is a painful test. So many patients are not willing for that. So depending upon how much somebody is comfortable, we do the test. But at least 2 measurement of MRD should be done on maintenance therapy also. Somebody who's not a transplant candidate, and there, when you are trying to put the patient on maintenance. So before maintenance, we would like to have bone marrow MRD as well as the PET CT scan to see whether the aim of induction and consolidation have been achieved or not. And if those have been achieved, then we would like to put the patient on maintenance therapy by performing an MRD test by PET CT scan as well as bone marrow. Thank you.
Thank you. Thank you very much. Aditi, you wanted to ask some question about MRD negativity. So you can switch on your, you can unmute yourself and ask a straight question to Dr. Pankaj Malhotra or Dr. Neeraj or Dr. Stalin.
Hi, good afternoon. Thanks again for this program. I think the first part of my question, Dr. Malhotra already answered, which is, would you use MRD to assess whether a patient needs further consolidation prior to maintenance? And I think Dr. Malhotra sort of already answered that. Basically, my question was, I know that it's debated about de-escalating therapy based on MRD status, especially MRD negativity, but do you use MRD assessment to, make treatment decisions on continued treatment? Say if a patient potentially needs further consolidation with the goal of reaching as close to a deeper response, as close to MRD negativity at this time. And would that change if the patient was standard risk or high risk?
Yes. So yeah, Neeraj, you want to go ahead?
No, yeah, after you, sir.
So, so even though there are ongoing trials to look at this question, but I do use MRD for de-escalating the treatment or consolidating the treatment. And as you said, standard risk and high risk. In both the situations, depending upon what is the status, and Dr. Neeraj has already presented the information on MRD, the kind of a thing which is coming up. So it's a future kind of a thing. The trials will take time to show their results, but at least I would definitely use MRD as a tool for consolidation, de-escalation, escalation. I'm not sure, but definitely de-escalation. Thank you.
Thank you.
So can may I? Can I just?
Yes, Dr. Hari.
Please, Dr. Hari.
Yeah, so I was just listening to the thing, and I fully agree with what Pankaj has to say. But what one must understand is, where are you going to utilize the MRD, and in what context are you going to use the MRD? So currently, the thing that has matured in terms of utilizing MRD is to understand where your disease is heading to in terms of having some predictability for long-term outcomes for the patient and the efficacy of your treatment also. But it doesn't translate into whether, because a lot of factors that will determine whether you're going to be MRD negativity depends upon the biology of the disease. And we know that myeloma is not one entity. So definitely for the efficacy of treatment, we do understand that MRD is a definitive tool. But for us to decide whether we want to escalate treatment or de-escalate treatment, maybe we are not up there still now for utilizing MRD over there. So definitely the studies are going on in terms of whether we can stop maintenance therapy after 2 years of being MRD negative. That the results are still yet to come out fully, but intuitively one might think that there may be a merit in being able to stop therapy based on an MRD, but we'll have to wait for those results.
Thank you very much, Dr. Hari Menon. Now it's time to change the next topic. It is the CAR T cell therapy in multiple myeloma. And it's over to you, Dr. Hari Menon. And Dr. Hari Menon doesn't require any introduction. He's a well-known, faculty member and image member also. So over to you, Dr. Hari Menon.
Thank you. Thank you, Dilip, for that. Unlike Neeraj, I don't have any slides, so I thought I would just discuss the concept of CAR T cell therapy. And when I talk about the abbreviation of CAR T cell therapy, it's a little complex when you say chimeric antigen receptor T cells. It's a highly medical jargon that is there over there. But technically, to make it more simplistic, it's an option of therapy for myeloma. For example, it's an option for therapy for many of the malignancies that has emerged in the last 5 to 6 years as a definitive option for treating not all malignancies, but mainly many of the hematological malignancies. So as we know that cancer is amenable to immune mediation responses, immunological manipulations, and we know quite a few cancers that do respond to immunological. And today, in the era of immunotherapy, everybody is going about saying about immunotherapy and trying to harness the benefits of immunotherapy, be it using monoclonal antibodies or using mechanisms to try and teach the body's immune system to do the job that it is supposed to do. So there are various forms of immunotherapies that we do. And in normal practice, we have great immune surveillance that is happening in the human body, which does not allow for abnormal cells such as cancer cells to actually develop and proliferate and manifest as cancer. So that is why even though cancer is a disease of the older age group, it is not so commonly seen always, but you do see it more commonly in the older age group. And that is primarily because the immune surveillance becomes a little weaker as we grow older. Now, so what we do as far as immunotherapy is concerned is try to harness the immune system or to reawaken the immune system to do the job that it is supposed to do. And you do it through various mechanisms, including using antibody-based therapy, which is also one of the ways we treat many of the hematological malignancies, including myeloma, wherein we target certain receptors that are present on the myeloma cell, engage with those receptors to trigger an immune system to result in a tumor kill. So some form of a directed therapy. Strangely, when we talk about transplants, autologous transplants, though one would like to think it is a form of immunotherapy, strictly speaking, it is not immunotherapy because we are actually using transplant as a mechanism to actually reconstitute the bone marrow to allow for the recovery of the bone marrow. And there is really not much that the immune system is actually doing. Actually, it is a chemotherapy that we deliver as part of the transplant, which is actually doing the job and as an anti-cancer therapy. So let's get back to the other ways of dealing or harnessing the immune system. So one of the things that happens in patients with malignancy is whether it is like the chicken, the egg situation, whether it is because of a weak immune system that you have developed cancer, or is it because the cancer itself causes suppression of the immune system, allowing it for its survival. So we know that currently many of the cancers do have mechanisms to hide from the immune system in several ways. And so when you hide from the immune system, you are able to evade the immune system, and that results in survival of the cancer cells. So you can have an active immune system, but the cancer cell evades it. And so you try to open up or make the cancer cell visible to the immune system by certain mechanisms. And that's what we have come across as various treatments in the form of immunotherapy, where in 2017, the Nobel Prize was won for that particular concept, where you are making the cancer cell visible to the immune system, so the immune system can work on it for its for a cancer kill. Similarly, over here, the CAR T cell therapy is some sort of a modification of things over there. So we have the tumor cells on one side, and you have the immune competent cells like the T lymphocytes and the B lymphocytes. But over here in chimeric antigen receptor or CAR T cell therapy, you're actually harnessing the T cells actually. So you have on one side a lot of antigens that are present on the tumor cells, which are unique for the tumor cells, which are expressed on the tumor cells. And by binding to those antigens, you are able to generate an immune response that will result in a tumor kill. But when you are talking about not always all the T cells as we have do express those antigens that can actually go in and attach to those antigens that are there on the cancer cells, to create an immune response that will result in a cell kill. So what is done in a CAR T cell therapy is that you manipulate the tumor cells to make it express certain antigens on its surface, which can be combined with immunotherapy to target onto these receptors on the malignant cell, in this case, a myeloma cell, and some of the antigens that we use, which is commonly used, is known as a BCMA or a B cell membrane antigen. And you cause that expression of the T cells in the laboratory by using certain viral vectors, which will induce the expression of these antigens on the surface of the T cell. And then when you do that, you expand the T cells and give it to the patient. So you harvest the stem cell, you harvest the T cells from the patients, you make the T cells of the patient's T cells express those antigens, and then you put it back into the patient. So in some ways, it is a form of an autologous transplant, but you are giving them some sort of a new kind of a T cells, which will go and target those myeloma cells. In this case, when you're talking about myeloma, we're talking about myeloma. This same mechanism is used in leukemias and in various forms of leukemias mainly. And lymphomas, of course. So in myeloma, you teach them to go and target, and this has been immensely successful. But it is quite a labor-intensive process. It is an expensive process as of today, but with technology improving, I'm sure that is going to open greater avenues in terms of wider accessibility for this technology, but also in terms of being able to deliver the treatment much more quicker, because currently, when we're talking about delivering a CAR T cell therapy, it is going to take almost about 3 weeks for us from the start to finish to deliver the treatment. So that is one of the ways that we can use CAR T cell therapy over here. And fortunately, multiple myeloma is one such disease that is quite amenable to CAR T cell therapy. In fact, one of the diseases that has shown profound responses to CAR T cell therapy. You do have problems like you would have in any transplants with a CAR T cell therapy, but certainly it is an area which can be utilized very well in the treatment of myeloma. And so, as was true in our last meeting, which said extending survival in myeloma, the CAR T cell therapy is one such modality which can be used to extend survival in myeloma, and they have shown profound responses even in patients who have failed 5 to 6 lines of therapy, wherein you have importantly you have responses, and more importantly you have durable responses. But if you ask me whether it does cure the disease, well, not, but there is a possibility of using the CAR T cell therapy again, and there are newer antigens that have been identified on the myeloma cells, which is specific for myeloma cells, which can be exploited for this CAR T cell therapy. So why is it called CAR T cell chimeric? And because you're creating a chimera of the T cells, which is not normal to the T cells. So that's why it's called chimeric. And why is it called antigen? Because you're expressing a distinct antigen on the T cells. So that's why it's called an antigen therapy. So that's why it's called a chimeric antigen receptor therapy. Definitely a great technology, which can be harnessed for profound effect in treatment of many of the hematological malignancies, particularly myeloma. Yeah, thank you.
Thank you very much, Dr. Hari Menon. A wonderful explanation. And instead of going for a question answer now, we have our guest, Mr. Navin Kshatriya with us. Navinji, with your kind permission and yes, I would like you to share about the CAR T cell because he has recently undergone a CAR T cell therapy. So, Navin Kshatriya ji, would you please share in a few minutes your experience about the CAR T cell therapy? Thank you very much, Navin ji.
So Dilip, you really surprised me. I'm here as an attendee, but now that you asked me, yes, I did have CAR T cell therapy for my issue. I've had, before I went into that, I had several relapses and treatments, and including, of course, starting with the basic things of what is it called, consolidation, and then of course we had monoclonal antibodies. About 2 years ago, at the end of 2021, it was realized that my thing was not getting addressed. In fact, I was getting a relapse again, which is when I was told by my doctors that it might be best to see an option of CAR T, which is not available in India for myeloma at that point in time. I've had the good fortune of being associated with the doctor in MGH, Dr. Ragi, of Indian origin, and with her advice and my doctor in Bombay, Dr. M.B. Agrawal, it was agreed that I should try for this. Now, at that point in time, the availability of CAR T was not easy, given the fact that there are slots which are provided by these companies who have the cure or whatever. At that point in time, it was only one company, that BMS, which had the approved CAR T cell therapy for myeloma, and it had just been approved a year ago. So while it was not in experimental stage, it was still at an early stage, and it was not available for a few months. I also had certain other complications, which I won't spend time on for me to go ahead and take this, but that was resolved. And then I went in for that in the month of May, June. And as it was explained by Dr. Hari Menon, they extracted the T cells from my system and took those T cells to a laboratory. And they took about 4 to 5 weeks to have some genetic manipulation. And they brought back those things, and that was introduced in my system on 30th of June 2022. There are various kinds of risks which are there post the infusion, and there are neural responses, and I forget the other one, which is where you may have fever and others. And I had the misfortune of having both of them, and one was I don't know whether it was severe or not, but my doctors did tell me that I was talking a bit of nonsense on the first day. They have ways of judging the neural response by making you count backwards, etc., etc. And apparently, for the first half day, it was not a very good response, but I picked up very quickly. And then I had to stay in the hospital for about 10, 12 days, where they were watching my progress and recovery from those reactions. I just want to tell the group that there's nothing to worry. Huh?
Cytokine effects.
Yeah, cytokine effect. That's right. I forgot.
Yeah.
I just want to tell the group that not to worry about these things. These are common and they're managed well. So therefore, wherever there'll be greater and greater experience, the doctors out there will know how to handle them well. So it's not something which is which is really scary, but you need to be conscious of. So I was there for another month after my month and a half after the treatment, and they continued to monitor my blood counts and other things, and then I came back at the end of August. Now I've been a bit unlucky because I have a parallel issue which causes a fluctuation in my blood counts, or at least a depletion of blood counts. But that's nothing to do with myeloma. The good news was that typically this particular version of treatment, which is ID cell, had 74% response, and therefore you don't go in with a certainty that will work. And I was a bit lucky that I not only had a response, but I had a very, very good response. In the sense, the doctors mentioned that there's not a sign they could pick up. So MRD, which was being talked about, was negative at a very low level. And right, so and I keep now doing 6 weekly or monthly tests, which was mentioned by Dr. Siddharth in terms of FLCs, etc. And the good thing is my FLCs are well within control. The ratio is fine. And it's now how many months? About 8-9 months that as far as myeloma is concerned, things are under control, I would say. I have another issue, which is unrelated issue, which is causing me a problem. But that's the experience which I had. So I would say, I would feel that I got a response which was close to cure, but technically it is not cure, as the doctors would say. But hopefully increases the probability of survival, progression-free survival a lot more. Dilip, is that adequate?
Yeah, perfect. Thank you very much for sharing your experience.
And you should have warned me, then I would have done this better.
No, I sent you a message, but unfortunately you were busy, so you did not get my message. You have received my message, but you did not see it. But I would like to know our patients and caregivers and our doctors also that you have undergone a CAR-T, and your experience is very much important, because technically what we speak is one thing, and people who have undergone a real CAR-T, their experience matters a lot. Thank you very much for sharing, and keep on sharing and keep on inspiring and motivating us. Thank you very much.
I do hope that the Indian CAR-T efforts which are being done in Tata Memorial and other places come to fruition very soon, and they are widely available to people, because I do believe that this is a great step forward in terms of addressing the myeloma issue. People have to go outside at this point in time. And across the world, it's limited availability, and it's also really expensive. So I really hope something happens very quickly in India.
Right. So your questions will be answered by a few of our panelists, Dr. Hari Menon or Pankaj Malhotra or Dr. Uday or Dr. Stalin, please.
Hopefully we are in discussion, and we are probably going into the first in human probably by the third quarter of this year, through a clinical trial with an indigenous CAR for myeloma. Yes, we're working on that.
That's a very good news. So now the next session is about the impact of government scheme on patient outcomes. And our speaker is Dr. Stalin Bala Chaudhary. So over to you, Dr. Stalin Bala Chaudhary. Stalin Bala Chaudhary is from NIMS, Hyderabad. So over to you, Dr. Stalin.
Yeah, thank you. Thank you, Image, and thank you, Yodas, for this opportunity. I will just share my screen. Is it visible?
Yes, Yes, it is.
Yeah, I'm using the same PowerPoint which I have presented the data at the image. So my topic is how a government health scheme will have an impact on the outcomes of the myeloma patient. So predominantly, I'm taking the data of the transplant in myeloma, which at the NIMS. So we all know that the autologous stem cell transplantation is a key component of treatment, myeloma treatment in all transplant eligible patients. At NIMS, we transplant all patients who are less than 65 years of age. At our routine practice is to take 65 as cutoff, and majority of the times we are doing for all transplant eligible patients who are less than 65 years of age. And we know that although it is introduced in 1980s, it was not until 90s when the IFM trial had shown the substantial evidence for its superiority over chemotherapy. And although it is not curative, but it has a significant progression-free survival and in some clinical trials an overall survival benefit with manageable short-term toxicities and low treatment-related mortality. So, but various trials had shown some controversial results, but across all trials, there was a consistent progression-free survival benefit. In some clinical trials, there was a overall survival benefit also. And now we know that this is the current algorithm, either in the standard risk or in the high risk. The transplantation remains the standard of care after 4 to 6 cycles of initial induction chemotherapy. If at all patient is not willing in standard risk, they can preserve the stem cells and can do a transplant at relapse. But what in India, what I feel is when in a country like India, where the availability of the second line drugs is limited and they are costly, especially even it is standard risk, the transplantation in the first go is the best form of the treatment we can give to our patients. So this is the study which was done to analyze the outcomes of myeloma patients with autologous stem cell transplantation and how the transplant rates were improved with the state health scheme. And the data was analyzed from 2010 to 2022. So these are all the transplants which are done over a period of time. You can see the bar diagram, which is significantly increasing. So till 2015-16, the transplantation, the autologous stem cell transplantation for myeloma was not included in the state health scheme. After the 2016, so we from the Nizam's Institute of Medical Sciences, the Department of Medical Oncology has convinced the government that this is the best form of the treatment. We can give it to a myeloma patient. So if the main barrier to get autologous stem cell transplantation done in our patients, especially, we will see majority of the people are from the Telangana state and some people will come from the Andhra Pradesh too. So the main barrier for a patient to undergo the stem cell transplantation is the finances. If the government can support with the finances, can do it under a state-sponsored health scheme, it will significantly benefit the patient. So we can deliver the best possible care to the myeloma patient. So government has convinced, they had given permission, especially to the government cancer centers like Nizam's Institute of Medical Sciences and another cancer center called MNJ Cancer Center, which is nearby to the Nizam's Institute of Medical Sciences. So they have given permission only to these centers. So from 2017, you see the amount of transplants which were done. So in up to 2016, over a period of 7 years, only 15% of the transplant eligible patients. So out of 180 patients, only 28 patients has received, whereas in the 2017, from 2017 onwards, it has increased to 50%. And in the last 2 years, we have broken all the barriers for which a patient should undergo autologous stem cell transplantation, including the financial barrier. And almost 80 to 90% of the transplant eligible patients are receiving the autologous stem cell transplantation who are presenting to the Nizam's Institute of Medical Sciences. And as this facility is available to us and all the patients who are being treated outside also being referred for autologous stem cell transplantation to Nizam's. So especially in a country like India, where majority of the patients are poor, can't afford a costlier treatment like autologous stem cell transplantation, especially some form of support from the government can significantly improve the transplant rates and also improve the outcomes in the myeloma patients. So in the transplant, everything is included, the conditioning regimen and the plerixafor and the stay till the engraftment. So this is the outcome. Only 1% of mortality and almost 90 of the 100 cases we have done over a period of 7 years, almost 99 patients have survived and had got a good post-transplant response. And now with the incorporation of Ayushman Bharat into the Telangana Arogyasri scheme, the VRT component and the post-transplant maintenance also being covered for the free of cost at Nizam's, and all the myeloma patients who are presenting to the Nizam's are able to get every treatment under the free of cost. That is the initial induction chemotherapy regimen, the bone marrow transplantation, and also the post-transplant maintenance. Still, progression and our transplant outcomes are on par with the other published data, like the median progression-free survival was almost 4 years, with almost 2/3 of the patients are on follow-up and living at a follow-up of average follow-up of 5 years, which was consistent. So especially my topic is on the how the impact of government health schemes will be on the outcomes of the myeloma patients in a resource limited country where majority of the newer therapies are not available or unaffordable, and challenges of doing delayed transplants are there. So early transplant is the best way. And if we can incorporate and can do it at a subsidized price or under the free of cost under the state health sponsored scheme, definitely it can increase the transplant rates and impact outcomes in the myeloma patients.
Yeah.
So this I had presented at the image conference, so that so it should educate all the myeloma physicians who are treating myeloma patients all over the India, so that it is harder for a thing to incorporate on a national level. So it should be especially on a state level. Now, the two states of Telangana and Andhra Pradesh both have included the transplant in their state health sponsored scheme. And even in Andhra Pradesh, all the myeloma patients who are transplant eligible are getting it under free of cost under the state sponsored. So if at all the individual physicians of the state can approach the state governments and can include it, definitely the transplant rates can be increased and the outcomes of the myeloma patients can be improved.
Thank you very much, Dr. Stalin. Basically, from Myeloma Friends India and Yodhas, as a patient advocates, we would like to, have your presentation, what you had presented to government and approved this particular, treatment, the transplants made free. So we can take it to other states also, maybe pan-India level also, and try to get the same scheme available in all the states and all government hospitals, so that we can treat more and more myeloma patients. Right. So we will definitely get in, Yodhas and Myeloma Friends India will definitely get in touch with you.
Yeah.
Thank you. Thank you. Yes. Vinita would like to say something. Vinita, you can come. Unmute yourself, please.
Yes, I think Dr. Stalin's presentation was excellent, and the impact has already been shown. Having government scheme as a part of treatment for myeloma has been really, really effective. As I think Gayatri has also mentioned it, and I've also mentioned it, we need to move on this as patient advocates, especially in myeloma, to move it in all the states, and especially states where there is a financial crunch and the large number of population is unable to pay for it. And it is an extremely sad thing that if it is not available to people who really need it, then we need to really move on it. So I do hope that at least by the end of maybe let's give ourselves a year, that every state should be in a position to be able to have the same kind of government schemes that Telangana has. And I think that would be really icing on the cake for myeloma patients. Thank you.
Thank you, Vinita. Now we are shifting to the last session of this. Few questions can be asked because we are nearing to our timing. So we have 7 minutes, so we can definitely take few questions from the audience. So please raise your hands, please. Whoever wants to ask any question.
I think, Mr. Dilip, there are few unanswered questions here. I think.
Please go ahead, sir.
So one is, Hari sir, you can take on this question of CAR-T therapy to be given after the age of 70 to patients not eligible for bone marrow transplant. Just to reiterate, you already mentioned that in your talk, but just to reiterate and clarify it for the people. Sir, you have to unmute yourself, sir.
Yeah, so age is really not not a reason why we cannot implement the therapy. That's true for transplant. That's true for CAR T-cell therapy also. But we have to anticipate certain problems. That is, what is the quality of their end organ functions, like the renal functions, the cardiac status, the respiratory status, etc. Before advising such therapy, because once you implement the therapy, we are expecting certain side effects that will, and the patient should be able to withstand those side effects. So that assessment is always made prior to subjecting a patient to transplant. Age itself is a relative contraindication, and if you look at it, even transplants are done at the age of 75 and 80 also without a problem. So that holds true for CAR T-cell therapies too.
So can I just add one line? So I got
sir,
this
please.
therapy done at the age of 74.
Yeah.
I don't have any major issues in terms of kidney or heart, etc. That helped.
Yeah.
But I saw other people also going through it, and they're not necessarily excluded because of age.
Yeah.
But it's basically, as rightly said, the ability to withstand the side effects.
Yeah.
Thank
Yeah,
you.
wonderful.
Thank you.
Yeah,
Naveen.
yeah, please, yeah, Mr. Dilip, please take it forward.
Yeah. There is another question to Dr. Hari. At what stage should someone consider immunotherapy or a CAR T-cell therapy? It is about the eligibility criteria.
I didn't think whether it's about the eligibility criteria, because I did reply to this question.
Yes, sir. You did reply, but
So the thing is, normally the CAR T-cell therapy currently is being offered to patients who have multiply relapsed, and they are looking at patients. Normally, when it was introduced, it was patients who have failed more than 5 lines of therapy, and that is how the normal sequence of events that happen before approving them into more upfront management. So nowadays, one might even look at giving a CAR T-cell therapy after failure of 2 or 3 lines of therapy over there. So there's really no reason, because it is quite an effective therapy. It is emerging as a very effective therapy, more doable in patients. The only reason why it was really difficult to implement was the cost associated with it, and also the availability of the treatment on a bigger scale, which I dare say would change in the next 2 to 3 years.
So I have a question.
yeah,
Yes.
please.
Yes.
So you mentioned, Dr. Menon, that this has been successfully used in leukemia.
Yes.
And I'm quite aware of it, but is that happening with in India? Are they using CAR T in India for leukemia as well?
Yes. At Tata Memorial, they have their indigenous CAR T cells, which have been used even at Narayan Hridayalaya with the Biocon, with Siddharth Mukherjee. Immunil has come up with a few of them have been treated, but more so for childhood acute lymphatic leukemia, not so much for acute myeloid leukemias, but it's mainly for B cell leukemias and lymphomas where it is more used. And it has been the process. In fact, they have finished their phase 1 study at Tata Memorial for indigenous CAR, for CD19 CAR for B cell ALL, and they are going to the next phase of more multicentric studies.
Thank you.
Thank you very much. Sir, एक last question है.
No.
What if
No, I just called. I just finished this.
Vinita, please mute yourself, please.
Sorry.
Yeah. Sir, last question is, what if CAR T-cell therapy fails? What is the next treatment available for myeloma treatment?
So it is just in the sequence of treatment for myeloma. Fortunately in myeloma, something or the other has always emerged to improve or extend survival in myeloma. So we do understand that there are other ways of immunotherapy also that are coming in. Currently for treating myeloma with a CAR T cell, the target antigen that we are exploiting is the BCMA or the B cell membrane antigen on the myeloma cell. But there are newer antigens which are more robust also, that are being identified on the myeloma cells. So some of the, curiously, some of the more recent data have shown that if you were to exchange the, utilize another antigen for CAR T-cell therapy in the subsequent, you still are likely to get a result. But these are in the early phases of treatment. You do have bispecific antibodies that can be used, and there have been some data to show that it may still be effective in patients who have failed CAR T-cell therapy. And that can also be used in some patients. So that is also there. But more interestingly, it is switching the antigen target that may be useful in still using the CAR T-cell therapy, but against another antigen on the myeloma cell.
Thank you very much. And we are coming to an end of this particular webinar. And I thank you very much, Dr. Hari Menon, Dr. Neeraj, Dr. Pankaj Malhotra, Dr. Y. Uday, and Dr. Stalin Bala Chaudhary, and people who have shared their experiences, Ms. Krishna Veniji, Naveen Kshatriya ji, and everybody who have asked questions, and people who have joined on this particular webinar. We thank you very much from our bottom of our heart, from Image Society, from Myeloma Friends, and from Yoddhas. So over to you, Dr. Uday, for the closing remarks.
Thank you, Mr. Dilip, for helping me out in moderating this session. So sincere thanks to you. Okay, now there are a couple of announcements that we have from the Image. So first of all, coming to the agenda for the next Monday meeting, we are going to have the next Monday the discussion on infections in myeloma, vaccinations in myeloma, and bone health in myeloma. So the three important things wherein we are going to talk about how can you prevent infections, and how can you, what's the current strategy as far as our country is concerned on vaccinations, and most importantly, bone health. Bone health just does not mean medicines, but how can you take care of yourselves? So we'll be talking on these three important topics to you people. So that would be the next Monday's agenda at 4 o'clock in the evening. Now, second, we from Indian Myeloma Academic Group have actually been helping out patients with the drugs for transplant. So we have some funds available from Image, wherein any patient who is having a below poverty line card and is going to get a treatment from a government center, we are there to take care for your drugs for the transplant. So whatever drugs are required for the transplant, that will be taken care to a maximum ceiling limit of 2 lakh rupees per patient. So we would be helping out on that. So it's some baby steps we are taking. We might not be able to take care of the complete country as of now. So we have taken out of the applicants, the top 10 most deserving applicants will be taken care by a committee from the Image who will decide on these patients and will try to help them out with the transplant. Because as you have heard from Dr. Stalin, the most important thing is doing early transplants can really change outcomes in our country. That's number 2. Now, number 3, thanks to Dr. Pankaj. So he has actually come up with the idea of having these patient group meetings with the Image even after this month of March. Though we actually started this as a myeloma awareness month every week, we are going to have a quarterly meeting with all patients across the country, with all national experts. Here we are just having 3 or 4 national experts, but we will try to get more national experts, more patients from across the country, and also few international experts on board, wherein people can ask us questions. And to streamline things, we will request Myeloma Friends and Yoddhas to collect the queries beforehand. Rather than having a lectures here or a seminars, we collect the questions from over a period of 3 months and we answer those questions one after the other. So that way we will be able to actually solve the patient's problems more rather than we trying to teach them something. So that's another thing which we would want to announce from the Image. So with this, I would hand over the stage to the president of the Indian Myeloma Academic Group, that is Pankaj sir, to give a closing remark and announce the closure of the meeting.
No, so the closing remarks have already been done. I think Dilip ji has done a wonderful job, and so is rest of all of you by joining. Just by joining, you have shown the solidarity with the Indian Myeloma Academic Group, MFCT, and Yodhas. So, and it also gives us the opportunity in a routine busy clinic. We don't get so much of time to interact with you. So this is an opportunity where we are trying to share few things. And I always say the learning is both ways. We also learn from you. So it is not that we are trying to teach you. We are learning from you. We are sharing the knowledge which we have, but we also learn from you. And once we learn from you, we share the same knowledge with other people. So hopefully to see you in many more numbers next Monday, and then next to next Monday. And take care till then. Thank you so much.
Thank you very much. Thank you very much, everybody.
Thank you. Thank you very much.
Thank you. Thank you so much.
Thank you. Thank you so much.
Thank you.
Wonderful session.
Thank you.
Thank you.
Wonderful session.
Sir, see you on 18th.
Yes, we
Yes,
look forward to
definitely.
that.
Yes. Yeah, definitely
Thank
see
you.
you on the 18th.
Thank you.
Thank you.
Thank you.